it time yet?
It is time. Let's
All right.
go ahead and begin.
All right. Hi, everybody. My name is Andrea. I'm a second-year resident at Virginia Tech.
I'm Josh Goldstein. I'm attending at Mass General Hospital in Boston. For those of you in the back, by the way, there are some seats if you want to come up this way. There's a few over on the row over here, a couple up here. We'd love to have everybody. Thank you all for joining this session.
We are super excited to be kicking off SAEM with one of the first sessions. It's going to be a didactic on improving survival of intracerebral hemorrhage, looking at state-of-the-art strategies and research targets. We have an excellent panel discussion for you today. Two of us have disclosures. Everyone else has nothing to disclose. We're going to be structured in 4 different sections. Each are 10 to 12 minutes. The first one will be by myself and Kyle. We're going to be looking at reviewing current best practices in intraparenchymal hemorrhage, blood pressure control, and hematoma expansion mitigation. We're going to be identifying gaps in care and highlighting areas where current practices aren't quite meeting the mark. We're looking for innovative treatments and developing areas where you might be interested in conducting research at your own institution. So without further ado, I'll briefly introduce why you should care. Intracerebral hemorrhage is a major presentation to the ER. There are 18.9 million ICHs a year in the US. This is in 2023 alone. Stroke as a whole is the #2 cause of death in the world and the #1 cause of long-term morbidity and disability. So obviously a major player in the US healthcare system in our emergency department, something that we see frequently. So our sessions are broken down into hematoma expansion mitigation, ICH risk stratification and neuroprognostication, hyperacute management bundles in the pre-hospital setting very briefly, and then also palliative care for the emergency department for this setting. So now we're going to start with our first session, which is advances in hematoma expansion mitigation. That's me, and then also Kyle. Kyle is a pharmacist, and he is our leading expert who's going to run us down on all of the drugs that you need to know and how we got there in the research. So here you go.
Thanks, Andrea. Good morning, everyone. Thank you guys for joining us. So just real quickly, the objectives for this subsection is to understand the pathophysiology behind blood pressure targets for ICH and to know which antihypertensive agents are appropriate to use in these patients. We're going to briefly review some of the reversal agents that are available for patients with an ICH that are on anticoagulants, and then understand the different role and indications for surgical interventions for patients that are presenting with an acute intracranial hemorrhage. This slide looks very busy, but it's a summary overview of the available literature for blood pressure management. So I kind of labeled them into 3 separate categories. So the first 2 studies go together and they're labeled with bullet point 1. Interact and Attack, 2 trials that looked at intracranial hemorrhage, patients presenting with systolic blood pressure greater than 180 and having different targets. But what they're really finding in this study was that that systolic blood pressure of 140 within the first 6 hours was probably a good initial target to look at. They didn't see any long-term outcomes, but they did see some positive frontline results. And then the same authors, repeated their studies with a little bit of different take, looking at a narrower window of time. And that was Interact 2 and Attack 2. So this group, they found, that blood pressure target, it's not just 140, but it's maybe a range, and that it was safe to target that range of 130 to 150 within that first 1 to 2 hours. And then, we move along to the third study, which is Interact 3. And now we're talking about that bundled care where blood pressure intervention was the largest, intervention in that group. And they were trying to see, how quickly could this be implemented and how aggressively could we lower blood pressure? And they found that, around 140 is still the correct answer, but harm might be seen if we lower it below 130. And it was safe to do it within the first 1 to 2 hours. So what is our final recommendation if we compile all of this literature and what do we walk away with? It really is that we should be targeting that blood pressure in that initial phase until we know exactly what the cause of the bleed or potential interventions in that 130 to 150 systolic. Lower it within the first 1 to 2 hours, but going lower than anything than 130 probably causes harm. So antihypertensives, what's our considerations? So the first one is what type of access do we have? Patients' comorbidities, do they have heart failure? Do they have volume overload? Can they be managed with an infusion, or if they don't have quality access lines, we need to manage it with bolus medications. And then also consider the pharmacokinetics of the drugs. Very briefly, I'm going to touch on why we would use certain agents, why we'd avoid the other ones. So obviously, most of you are familiar with nicardipine. Maybe your institution has clobidipine or you use labetalol. I would say nicardipine is probably the workhorse for most of our institutions. It's an easily titratable drip with fast onset and quick offset. Labetalol infusions have really fallen out of favor based on the long PK half-life. And other agents that you could use, but probably don't see a whole lot of, is nalopril, hydralazine, and esmolol. Esmolol not having a great blood pressure effect. Hydralazine is rather unpredictive. And then agents that we're definitely going to avoid are going to be your nitroprusside or nitroglycerin. This may increase ICP and could also lead to further hematoma expansion. So we don't want to see those agents. I have seen, someone go in to enter nicardipine and unfortunately put in a nitro drip, not on purpose, but it can happen. So reversal agents, again, very briefly, just to be aware of what we're dealing with and what alternative products might exist. So when we're dealing with a warfarin overdose, it's going to be, or reversal, we're dealing with 4-factor PCC and vitamin K. Balfaxar is a new agent that came onto the market within the last year and a half. Your institutions may have switched, but it's really the same thing as Kcentra, which most of you are familiar with. You can also use FFP or alternative like APCC or 3-factor products. For our direct thrombin inhibitor, or dabigatran, there's a specific agent, intracizumab. Again, familiar, 5 grams times 1, give it. And if the patient's dialysis, they mean go for dialysis or be redosed. You can also give 4-factor PCC. And then finally, your DOAC factor 10 inhibitors. I'm not going to get into the debate of Andexxa or PCC today. You can find me afterwards. I'll be happy to talk to you about it more in depth, but those agents are both available for use. And then when we get outside of the anticoagulants, what are some of the other reversal strategies we want you guys to be aware of? So our fibrinolytics, alteplase, or many of you have probably switched to nectaplase. You can give tranexamic acid with cryoprecipitate. I think it's very important that we know that both those agents need to be administered together. One to provide the fibrinogen storage to cause the clot, and then other ones to promote clot stability. If you're still using alteplase, stop the infusion if you have symptoms. Our irreversible platelet inhibitors, so you have your clopidogrels, your aspirins, there's not really going to be much you can do to remove the drug, but you can at least administer platelets if they're going to go for a neurosurgical procedure. And finally, a new target that's maybe going to come to the FDA approval, bintracimab. This is an actual reversal agent for ticagrelor itself, and we'll see if they end up making it to market. They're still going through a review. So last thing I'm going to touch on, just again, very briefly, there is an inherent risk of developing a clot in a patient who has an ICH in general. They're bedbound, they're not going to be able to move. But if they are on an anticoagulant and now you reversed it, you've immediately increased their risk of a VT event occurring. ICH in and of itself has a 3 to 7% increased risk of a VT event compared to other hospital or critical illness. So restarting that VT prophylaxis right away, or as soon as neurosurgery, says that they're stable to be on it, it is a best practice, and we say that within like the first 24 to 48 hours. I'll hand it over to Andrew.
Okay, I'm now going to go over some of the procedures that you may or may not have seen at your institution that people are using to treat intracerebral hemorrhage. I put it in the context of time. The prehistoric era is all relative. It's all within the last 100 years. So nobody really should be doing a decompressive hemicraniectomy or doing an open procedure to go after a clot. We have really good evidence from 30 years worth of data at this point from Stitch 1, Stitch 2, that show us that going in open does not improve your functional outcomes. You have then the increased risk of undergoing a brain surgery. So we know that this is not the strategy. The only indication for a decompressive hemicraniectomy in someone with a hemorrhage is a posterior fossa hemorrhage in which you're decompressing the ventricles to alleviate some ICP. Otherwise, even though it might look like it's sitting right on the surface, please don't go after it. Moving forward in time, you have the Middle Ages of neuroendoscopy. This came about in the 1990s and really started to get more popular in the 2010s. These are devices that are CT guided with their placement, and this is an example. This is the BrainPath device. You might have seen this at your institution. It's about the size of an 8.5 ET tube, and you sort of map where you want it to go relative to where the hemorrhage is. and you do, it is still technically a craniotomy because it will not fit through a burr hole. So there is some inherent risk in that. And you have to develop your path to get to where you want to go. Then you can aspirate. And then in more recent studies in the late 2010s, you can also instill later on thrombolytics to break up any clots to further extract hemorrhage. So studies that looked at this included the ICES study in 2016, MISTY 1, MISTY 2, and MISTY 3, going up until as late as 2019. The gist of these is that these are good in the appropriately selected candidate, and those are very focal lobar hemorrhages that are close enough to the top that you inserting this device into the brain is not going to cause more damage than the bleed itself, because as you can imagine, inserting a sizable tube through tissue that's delicate is not ideal, and that has its own risk and damages that it can do. Moving forward to a bit of a more advanced version, and maybe you've seen some of this. These are the stereotactically guided, minimally invasive devices like Artemis and BrainPath Apollo. These BrainPath Apollo, this one on the right here, is a little bit similar to the ones in the past. However, it's designed to be smaller and deliver the same kinds of things using stereotactic guidance, which is just mapping of the surface of the brain using CT and a live sort of navigation system in the OR. Artemis is really cool. It's a handheld device that you can just do a single burr hole. You have to, again, have the appropriately selected patient where things are at the surface and you're not doing a damaging track to get to where you're going. But again, it goes in, it aspirates. There's recent studies looking on if you can incorporate cautery into this, and again, looking if you can incorporate instilling of drugs like alteplase to break up any clots that you might encounter while you're struggling to aspirate. So with that, we have gone through all of the ways that we can mitigate hematoma expansion, and I'm now going to hand it off to Peter Penagos, who is going to discuss risk stratification and neuroprognostication.
There are still a couple of seats up here. I know there's a lot of folks crowded in the back. You can maybe go along the side there. There, a couple of seats here, one up here, and one right over here too.
Great. Well, thank you. And this is, wow, what a wonderful attendance this morning. Would not expect this at 8 a.m. on Wednesday morning. We'll see what happens on Friday as the week goes on. But so certainly in your post-meeting review, say anything that involves the brain needs a much larger room. Please tell the organizers that's important. So with all that said, I'll talk a little bit about prognostication, stratification for ICH. We spend a lot of time on ischemic stroke in our stroke centers, and we seem like we just kind of work really hard on ischemic stroke. We have a lot of pathways in place, and then once we get the patient to the CT scan, everyone's at the bedside, we look in the scanner, we see ICH, everyone kind of walks away and goes back to their daily tasks. And there's a lot to do still in the hyperacute period for ICH, and hopefully what you'll hear this morning are there are things we now can do as emergency physicians that may impact the short-term and long-term care. And the issue is, once we identify an ICH, is there anything we can do or tell the family, or if you're working in a community hospital, predict who needs an urgent versus emergent ground versus helicopter transport? So are there any decision tools that may help you in that discussion? So hopefully there are a few key points I want you to take away today. These are fairly brief, but I want you to at least be exposed to a couple key concepts. Talk a little bit about the importance of early risk stratification, and talk about some bioimaging scales, which are going to be Spoil Alert CT scan, which is really our point of care testing in the emergency department. Talk about serum biomarkers, and then some clinical scoring systems. The biggest risk factor for, as we heard, for ICH is going to be hemorrhage. Number one, number two, number three. It's one of the great risk factors that really brings all stroke together. And the number one cause of ICH are lenticular striate or deep brain kind of feeder off the MCA, usually due to uncontrolled hypertension over time. And this is the most common and also can cause the most damage, because the basal ganglia and closer down towards the brainstem, all the fibers, the key fibers for the brain, will actually funnel through there. So you get huge deficits for very small injury or clot formation. So what are the things we can do when we see a patient that's on the CT scanner that are obvious predictors of worse outcome? The biggest one is going to be volume. Larger ICH volume, we'll talk about measuring that, is really a worse prognostic factor. It's kind of intuitive, but bigger is worse. GCS, a patient comes in with a low GCS or altered mental status at front, is also a prognostic factor. And then any presence of interventricular blood, particularly third and fourth ventricle, which in itself is a future predictor of obstructive hydrocephalus, is also a predictor of poor outcome. And then it's not a surprise, advanced age, either sex are kind of a predictor of worse outcome. And then deep lobar presence, also same case. And if the patient presents already with cerebral edema or in herniation, again, a predictor of worse outcome. And these are things, as we talk about decision rules, we kind of guide your next steps and the conversations you have with the family, patient if they're awake, and your consultants either on site or via transfer. So the question is why? The severity assessments early on really are going to help to drive our urgency of intervention. We heard there are surgical options. That often requires transfer or consultation to neurosurgical colleagues at a remote comprehensive center or on site. It optimizes our resource, particularly if you're transferring a patient. Do we want to activate a helicopter to transfer someone to a comprehensive center at night with marginal weather if the immediate impact or care that's going to be provided is not going to be critical in the first 6 to 8 hours? So these are things that help us, and then they help to predict functional outcome and mortality, though as you're going to hear, potentially we don't want to use that to drive our initial practice for ICH. And then clinical trial enrollment. Any patient, if they are eligible for clinical trial, if there's clinical equipoise in the field, should be considered for ICH trials. And many of our comprehensive stroke centers in a network called StrokeNet are enrolling patients in ICH trials. And then time is brain. We hear that for ischemic stroke, but time is brain with blood also for rapid reversal, as we heard, blood pressure management, and then surgical decompression. So we'll talk about some of the current options. I think everyone in this room should have heard of this, but it's something that you need to use, and at least someone in the stroke team needs to do this, whether it's yourself in emergency medicine or your neurology or neurosurgical consults. It's also a quality indicator for Joint Commission for folks who are in comprehensive centers who admit patients for ICH, is doing an ICH volume. And then we need this actually to calculate the ICH score, which is a quality indicator. Pretty easy to do. With AI, this often can be done with estimated spheroid volume, which can be done pretty quickly, but it correlates well with CT scan, but very easy to do yourself. And as a reformed history major, even I can do this. So what you need to do is, one, first identify the hemorrhage, then pick the slice with the largest volume of ICH, and then just using your tools online, look at the largest axis, which is A in centimeters, perpendicular to that, the widest, and then scroll up and down, count the number of slices where the ICH is present, times usually 0.5 centimeter, which is the standard slice thickness for most multimodal CT scans in 2025. And then multiply A times B times C divided by 2, and that gives you a rough ICH volume. And that is really important. And that's important if you're remote and can't share your imaging with your consultant to say, I have an 85-year-old patient with a with a deep basal ganglier ICH with a ICH volume of 50 mLs with a GCS of 3. Those paint a really good clinical picture. So ICH volume is important. IVH assessment or ventricular assessment, there's a score out there. I don't use this personally and have not used it, but I think what it does is give you a convention on how to look for interventricular hemorrhage, looking at lateral ventricles, third and fourth ventricles, which particularly are going to be more critical because as you get further in the collecting system for the ventricular system, the further blood goes downstream, particularly in outflow areas of the brain, like the fourth ventricle. If you already have blood in those ventricles, those patients are going to be at higher risk for short-term hydrocephalus, obstructive hydrocephalus, and may need an EVD or acute neurosurgical management. So you can calculate this. There's a way to do that as a score. And if you certainly want to get bonus points with your neurosurgeon, you can do that. It's important to know what we see in the emergency department often is not the final story. Most of the patients we see with ICH, our static image, our initial CT scan is just the beginning of their journey. About 3/4 of patients who have ICH are going to have expansion in the first 24 hours. So not only are they having a bad injury, it's going to get worse. So as we should ask, is there something we could do to prevent that? And that's kind of the source and kind of the impetus behind this session. About 2/3 or 1/3 are going to have significant expansion in 24 hours, some of that in our domain with increased boarding, and about a quarter of those are going to have it within the first hour. And then we know the difference between ischemic stroke and hemorrhagic stroke is that the 1-year mortality for anyone with an ICH is about 50%. So as these hemorrhages expand, you're more likely to have worse outcomes. So just have to know that. So what can predict that? We know one of the things that we know in 2025 is something called the spot sign. And that is a radiologic marker that predicts expansion. So it's kind of a blush within the hematoma that on first pass through a CTA shows potentially ongoing extravasation. And this may predict a patient who is high risk for short-term bleeding and actually will benefit from acute therapies in clinical trials. And there are trials going on right now that are looking recombinant factor 7A for treatment in patients called FASTIS. And through the second iteration of that trial, which is done under StrokeNet at many of our comprehensive centers, we are looking to enroll patients who have that. And the definition of that is just a multiple or serpiginous spot-like foci within the hemorrhage that's not present on a non-CT scan, that's within the hemorrhage that actually looks like it's an active bleed. And here's a couple of examples of what that would look like. And then within StrokeNet, within our new fastest trial kind of protocol, which is version 2.0, we are actually looking specifically not only for ICH patients who are spontaneous and not on anticoagulation, but patients who have an ICH and have a spot sign, and they are candidates for factor 7A. So this is kind of cutting edge, and we're doing that as we speak right now. And we've only enrolled a couple patients in this new iteration of this trial. So next things we do, current treatment options, biomarkers. Are there any blood tests we can do to determine who's at high risk? Certainly we know we have biomarkers for brain edema, ischemia that are due to oxidative stress, vascular, angiogenic factors, and then coagulation markers. And many of those which have been studied, and 2 of those have a higher AUC, but really there are no shelf-ready biomarkers that we can do to predict who's going to have a worse outcome. Spoiler alert. So I ruined that one for you. So you can't really count on biomarkers. So clinical scoring systems, this is another key thing that I think we need to be aware of and be comfortable using. ICH score. Most of our EMRs have that as a calculation tool built into a stroke pathway. It's important that we at least start to work on this because it is a quality indicator for the Joint Commission. So easy to do. You score GCS what you see. You look at ICH volume. Remember I told you that was important a few minutes ago. And you give them a point greater or less than 30. Is blood presence in the ventricles, yes or no? Is it in the cerebellum, infratentorial area, yes or no? And do they have advanced age? And then you score them, and the higher the number, the more likely they're going to have chance for death in the first 30 days. And that's pretty useful for a prognostic scale. So the question is, how do we use that information? There's another score out there, max ICH score. I don't use it. I don't know if anyone else uses it. It's out there. I put it out there just because for disclosure that there's some places that use that. I don't. So the question is, once you get this information, we have prognostic information, what do we do with that? And this is the AHA updated ICH guidelines. And I think, Josh, were you on this? You probably were. So he's in there somewhere. So the issue is we specifically wanted to kind of address what do we do with prognostic factors for patients in the emergency department who have spontaneous ICH. And what we came down to is that patients with spontaneous ICH, baseline severity score or ICH score is reasonable to provide a general framework for discussion with the patient and the caregiver. And if I had an 80-year-old with a high ICH score, I can tell the family that we know that patients with similar clinical genotype will potentially, I wouldn't use that terminology in the discussion with the family, but it may have a mortality at 1 month of 80%. I'm not saying that is going to be necessarily your journey, but we know patients that look similar to this are going to have a very challenging outcome profile. So that is really good. And it also may direct who you're going to transfer emergency versus urgency, or it may lead to the discussion with the family with shared decision making, and patient you leave local for conservative and palliative care in your local hospital versus transfer. The second point, which just contradicts what I just said, is we shouldn't use that severity score as the sole basis to determine prognosis or life sustaining treatment. So though we can provide it as a discussion point and a prognostic factor for patients, we shouldn't use it as itself to say, sorry, your ICH score is high, we have nothing to offer you, we'll admit you to the floor where we can expect to die in 24 hours. We shouldn't be using it in that context, but it's useful to give the family some perspective. So in general, risk stratification is possible. We have tools available, easy to use. Imaging biomarker really is our point of care for ICH. Biomarker from the serum is not really ready for prime time, and decision rules can be helpful for transfer, for bedside conversations with the family, but shouldn't be used specifically and solely to determine resource utilization. All right.
Yeah. Our next speakers, we have Dr. Matthew Ball and Dr. Chaz Weira to talk about hyperacute initial management bundles for the ED border.
Wow, what a crowd at 8 a.m. Thank you all for coming. I'm Matt. Well, there is our learning objectives. You can read at your leisure over the next 2 seconds. I'm Matt Ball. I work at Henry Ford Hospital in Detroit. I'm also the program director of our new EMS fellowship. Residents take note. Just thought I'd put in a plug. And I'm going to talk about really the hyperacute management, as in what the pre-hospital, out-of-hospital management looks like. And just to level set a little bit, in terms of general EMS considerations, please be involved in your EMS systems if you want to influence the care of these patients before you see them. And if you want them to come to your hospital a certain way, that's how you do it, is by involving yourself. The other thing to note is that there's not really yet a great way to diagnose ICH in the pre-hospital environment. So we're going to be talking more so about destination and diagnosis as opposed to talking about therapeutics, prognostication, et cetera. So just to level set. And that's especially important because you need to choose which path you're going down, because the managements are diametrically opposed, right? It's permissive hypertension versus lowering the blood pressure. It is giving clot busters versus possibly giving things that help you to stem the bleeding. It makes intuitive sense that it would be impactful to know whether or not someone is having an ICH. But of course, that has been studied. This study enrolled 188 patients who were diagnosed with a hemorrhagic stroke in the emergency department. And they found that if it was recognized by an EMS clinician, basically all time metrics improved, whether that was response time less than or equal to 8 minutes, or on-scene time, or even when you look at hospital parameters like door to CT time, there was a marked reduction. The caveat there is that if you look at the bottom, the outcomes were maybe worse in the patients where EMS clinicians were able to pick up that they had an ICH, and really the authors think that that was because obvious strokes tend to be bad strokes. But all of these time parameters are like a necessary but not sufficient first step in improving outcomes. So this definitely does matter, our ability to recognize it. So there are a couple of pre-hospital scores that have looked at ICH. There's the Just 7 score that came out of Japan that looked at these 7 parameters: blood pressure, presence of arrhythmia, headache, dysarthria, et cetera. I won't read them out because y'all can read. It gave you a positive or negative number that you could attach to the probability of an LVO, ICH, or subarachnoid hemorrhage. This was retrospectively derived and then prospectively validated. And as you can see, this isn't the Lambs, this isn't the Cincinnati score, right? I mean, maybe y'all can do logarithms in your head and exponents of 20 decimal points, but this is more like something that would probably go on the iPad in the rig right next to the pediatric dosing pediatric dosing app. I won't, there's a guy in Florida who has one of those. I won't say the name because it's a name brand. But you feed these numbers and kind of the positive, negative of the conjugate deviation, headache, et cetera. And, what you're left with is an area under the curve of 0.79 is what they got retrospectively, and then 0.73 prospectively. And then in a validation study in 2024, they found 35.9% concordance with their first impression and like a 66% concordance with their top two. So good, but not great, but definitely a platform for improvement in the future. This was a secondary analysis of the FAST-MAG trial, which looked at administering magnesium to stroke patients, and they looked at 19 potential variables, and they found 9 impactful variables, and using a proprietary regression software that we've grayed out there. And feeding these 9 variables into the computer, they found something like a specificity in the 90s and the sensitivity in the 50s. And again, if you're making the decision to do permissive hypertension versus lowering blood pressure in the field, which we don't even really use antihypertensives in the field yet, but maybe we're just looking for a good indication, you probably need better numbers than that. So that's definitely a target of future research, is finding more accurate decision tools. And always in the world of EMS, we're thinking about transportation to the closest appropriate facility. So it would make intuitive sense that you'd maybe bring them to the highest level of care possible. Though, if you're familiar with the RaceCat trial, looked at bypassing the closest, what would be the equivalent in the US maybe of a primary stroke center. This took place in Spain for a comprehensive stroke center. They did a secondary analysis on ICH patients there. And I want to put this in context. There was a 40-minute difference between the closest facility that they could go to and what they viewed as the comprehensive facility. So that might not be everyone's situation here. It's not mine, where I live in, Detroit. But maybe like 30, 40, 50% of the US's population lives in that kind of circumstance. So if there is a big difference, maybe 40 minutes or so, they actually found a more favorable distribution of modified Rankin scores in the patients that they just brought to the closest stroke center as opposed to bypassing for the comprehensive one. So, if there's a 5-minute difference, I'm sure it makes sense to bypass. If there's a 40-minute difference, and this hasn't been validated by other studies, then maybe you don't bypass. And somewhere in the middle is the Goldilocks zone. Above this line, you bypass. Below this line, you don't. Another target of future research. And you may be sitting there wondering, why are we fiddling with all these numbers and things like that when you can just put a CAT scanner in a truck? And so that's an MSU, right? Not Morehead State University, go Eagles, but a mobile stroke unit. And when you think about mobile stroke units, I don't want you to think about just a CAT scanner in a truck. Think about the staffing, right? A lot of times they have PAs on board in a connection with the stroke system, so there are kind of ongoing costs and logistics, and it's always on the wrong side of the city that you need it. But there have been investigations into mobile stroke units and hemorrhagic stroke. This one came out of Berlin, the Be Proud study. It enrolled 154 patients with ICH. And if you look here, the primary and secondary outcomes, they looked at time to blood pressure reduction. This was a convenient sample, as it always is. Mobile stroke unit is only open during certain hours. But when it was open, they had a shorter time to reduction in blood pressure and transportation to the hospital as well. In general, other investigations into mobile stroke unit, this one came out of Australia, that just in general looked at parameters like, for example, they found that for mobile stroke unit patients, 46.9 had antihypertensives administered in the field. And, again, that's with a stroke team, a PA, it's not just, your normal city ambulance with a CAT scanner in the back. And really encouraging numbers here. If you look at arrival to CT time of 18 minutes, I mean, I don't know about y'all, but we're kind of busting our butts to get door to CT time in the emergency department, less than 15 minutes. And that's on top of recognition of stroke, calling into 911, 8-minute transport time, 5-minute scene time, loading them into the truck, and then, a 10-minute transport time. So, yeah, one more. Okay, I got you. Okay, let's see. And this is especially important because I'm going to reiterate a couple of points that other folks have made. Hematomas expand pretty early in the course of hemorrhagic stroke. And if you look at our mobile stroke unit data corresponds with kind of the hospital data that we looked at before. There's about a 27% chance of expansion. If you clock a bleed within its first hour, between the first and second hour, 27% of the time it expands in that time frame. If you clock it between the first and second hour, there's a 17 or 18% rate of expansion within the subsequent hour. So, I mean, really, the sooner you can get these folks to definitive care, you can really make a big impact on early hematoma expansion. And so what are the targets with that? I mean, if we could come up with a more definitive way to diagnose hemorrhagic stroke in the pre-hospital environment, we could give early antihypertensives. The aforementioned FASTEST study is enrolling 100 emergency departments and involves 15 mobile stroke units. So they're totally equipped to give medications like factor 7A as well. And I'll give the floor to Dr. Weiler.
Thank you very much. So I'm going to take the handoff from the EMS realm and Dr. Ball, and we'll talk about transfers and then the ED phase, primarily focusing on system considerations. And when evaluating systems of care models for optimization of the transfer process, there are multiple pragmatic, operational, and practical considerations to certainly incorporate. As has been said, every system is perfectly defined to get the results that it gets, be it good or bad. And colleagues of mine at Yale actually looked at this, created an ICH alert protocol at Yale with system refinements, optimizations, communication enhancements, with the ultimate aim of improving care across the entire transfer spectrum. And in one publication, Dr. John Sather, he basically piloted a multimodal intervention facilitating communication between EM physicians and neurointensivists and neurosurgeons. It was very nice because oftentimes with this, it would create a conference call that was kind of run by our centralized command center. They also refined local practice guidelines and instituted electronic medical record innovations with clinical decision support pop-ups and tools. And for results in the upper right table, you can see that there were significant reductions and improvements in ED length of stay, time to admission, boarding time, and time to reversal of coagulopathies as well. And there was a signal of benefit towards improved mortality. And then in the lower figure as well, it enhanced communication between all of the different service lines you can see as time evolved, which likewise was also a positive secondary outcome of the study. Now, as many know, in the ischemic stroke realm, there's robust work in the DIDO realm, door in, door out time, when we talk about transfers. But limited evaluations for this exist in ICH. And I don't know if she's here, but Dr. Royan from the University of Michigan and others looked at a pretty large analysis of DIDO times in the National AHA Get With The Guidelines stroke registry using data from roughly 450 sites. They found paradoxical results with better outcomes among patients with longer DIDO times, which was attenuated when adjusted for illness severity. The results suggested that EDs, and many of us fall witness to this, that EDs transfer out their sickest patients in a more expeditious way. But they did cite that further analysis with more granular data is needed. And now let's focus on the phase after ED arrival. And first, the work with, again, one of our panelists, Dr. Goldstein, who was involved in the publication on the left and the publication on the right. We do have both the AHA and European Stroke Society calling for code ICH bundles as well as ICH care bundles. And thus we have a call to action for ICH time-sensitive metrics, suggesting these for ICH code activation, coagulopathy reversal, blood pressure control, and many of the other things that prior presenters have mentioned. And the data shows that when bundles are accomplished, there's an association with improved outcome and decreased mortality. Now, as mentioned, part of this talk will talk about boarding, but we'll cut to the chase. There's really only one publication in the ICH realm, two on the side in the ischemic stroke realm. So for residents, future researchers interested in boarding, there's a paucity of literature in the neurocritical care realm for boarders in the ED. But what are the outcomes in this one study that looked at ICH patients boarding in our ED? It was similar to the Get With the Guidelines analysis as well, with paradoxical outcomes. The sicker patients got transferred to the OR, the sicker patients got transferred upstairs, and outcomes were better for those who did not need to be transferred. So that said, in this realm, there is more work to be done, but along the realm of the bundles of care, there has been recognition of the importance of instituting these bundles by national credentialing agencies, the Joint Commission, DNV, HFAP, and they all kind of like discuss many of the things that were talked about: ICH scales, time to blood pressure control, time to coagulopathy reversal. And these are certainly metrics by which comprehensive centers probably in the near future will be measured by. And so in closing, there's many opportunities for future research in this realm, as many of the prior presenters have alluded to, with one of them looking at rates of defect-free care and how can we, in the systems sense, augment and enhance that. So thank you very much.
Okay, our last pair is going to be Katie Mays and Chris Lewandowski. They're going to be talking to us about palliative care for intracerebral hemorrhage in the ER.
All right, so we're your closers, and we're going to do it quickly because we want to get to questions, but we're going to talk about, alluding to these other conversations we've had, what should you be doing? How should you approach these conversations? And in a palliative care sense, what can you be doing for your patients immediately in the ED, regardless of what you think their prognosis is? So really the role of palliative care in this setting is to provide comfort and also manage decision-making in the context of life-limiting illness. And so really just starting that goals of care conversation with family. There are a lot of challenges to palliative care in the ED, obviously, because we get this acute presentation. And as we've discussed, there is significant hematoma expansion. And so rapid deterioration is something that certainly can happen. And balancing these aggressive treatments versus comfort-focused care is something that's really important for us. Peter talked a lot about this, sort of what the poor prognostic indicators after ICH are. But the idea is that really we should establish goals of care early. So symptom relief, particularly related to pain, agitation, respiratory distress, and seizure prevention is something that's going to be really important for all these patients and something you can do regardless of how you think their life is going to turn out. And really kind of our goals as emergency providers are always to preserve dignity, minimize suffering, and align the care that we provide with the wishes of the patient and the wishes of their family in that moment too. Chris, do you want to come up and join too?
So really, Chris Lewandowski from Henry Ford. So really, the role of neuroprognostication is to give family members and caregivers an idea of what's happening and maybe what the future course is going to be, and to guide some appropriate intervention that are based on some of the patient's wishes that the family already knows. The tools that we have really, are the clinical assessment, the imaging, and the biomarkers that we've already talked a bit about. So we won't go over that. But early limitation of care is something that we really want to try and avoid in the first 48 to 72 hours. And, in this study, and I think the graph comes up next. Oh. All right, in this study, there were 270 patients with intracerebral hemorrhage. The overall mortality at 30 days was 43% and 55% for a long-term mortality. However, when you pull out the cases that actually had a DNR order written, so the very fact that you write a DNR order impacts the outcome of the patient, irrespective of controlling for everything else. So despite adjustment for age, gender, ethnicity, Glasgow-Coma scale, volume, intraventricular hemorrhage, infracutorial hemorrhage, you still have a much higher early mortality and late mortality by a factor of 2 by the fact that you've written that order. So it's really important to try and be as aggressive as you can, give a patient a chance, while actually talking to the family about really what realistic outcomes might be. So, the recommendation from the Neurocritical Care Society is to defer neuroprognostication and provide early aggressive care for up to 72 hours, and then use that time to see what the family really wants to do and what the caregivers really want to do. So you have to counsel them and you got to let them know that they may end up disabled, but it may take years for them to actually come back. So you can do aggressive care for the first 48 hours, a baseline ICH score, and then that gives you the framework in which to start doing that. So I think that ultimately, we have to do these decision-making kind of collaborative efforts in the early stages. You want to talk about this one?
So really, we wanted to point out that both the Neurocritical Care Society and the AHA have these similar guidelines that we shouldn't be making any neuroprognosis in the first 48 hours. And so while it's really important, and as we get better at neuroprognostication, maybe these things will change as we're using these models that sort of incorporate different things. But right now, the guidelines are very clear. And so you as emergency providers have this really hard task in front of you where you have to know that people are not necessarily going to have a good outcome, but yet you have to provide them with the best care that, to our knowledge, we have available at this time. And you also have to start this conversation. So while you can't finish this conversation in any way, shape, or form, starting it and understanding how we interact with a patient's wishes, how we start this conversation with a family of what their life might look like and how it may be very, very different than how it looked 2 hours ago. All these things are really, really important to sort of hold at the same time. So shared decision making with the family, approaching the patient, knowing what their wishes were, connecting with that family while we're calculating the ICH scores. We're not necessarily going to use them to change management all that much, and really just providing the family with very good communication throughout all of this is the almost impossible task that all of you have in front of you. So think about pain management in everyone. Think about sedation, anxiolysis. Think about respiratory support and seizure management. Even if these people have a low GCS, you need to be thinking about all of these things because we know that this provides a tangible difference in the experience that our patients have too. So while you may not be sucking out a clot, you can do all of these things for your patients regardless.
So, I have a little anecdote that probably 20, 25 years ago, my neighbor came to my house and said my mom had intracerebral hemorrhage. He said she bled in her brain and they want to take her off the vent and let her go, and I don't know what to do. And so he dragged me to the hospital where I didn't have privileges, and he convinced the nurse to show me the CT scan, and I said, look, in the words of Yogi Berra, it's really hard to make predictions, especially about the future. And and I said, give her a chance, and just go with aggressive care, and see how things develop over 72 hours as the edema starts to maximize or decrease and things like that. And ultimately, that's what they did. And she was 80 years old at the time and had a good sized hemorrhage. But 6 months later, she was playing bridge. And she was a little bit disinhibited, and so it was really fun to watch her play bridge. But she had another 6, 7 years of good life after that, and this dawned on me that we think we know what we're doing, but maybe we don't. And so I think giving people a chance up front is really important. And with my wife being a palliative care physician, it's always nice to get them involved early because they can actually do some shared decision making and assist the neurosurgeons. As you know, the neurosurgeons are generally pretty touchy-feely and really work well with families. So we don't want to usurp their role.
Okay, that wraps up all of our speakers. At this point, we're going to go ahead and open up the floor for any questions that you might have.
I was standing tall. A few questions with regards to the blood pressure targets that were mentioned early on. regard to all the studies, does the rate at which you decrease the blood pressure a matter? And two, is the set point of like 140 systolic, does that matter where you started from? Like what was your initial?
That's a great question. So some limitations of those early studies. And if you guys didn't hear the question, it's around the rate at which the blood pressure is lowered, and then what's the starting maximum blood pressure. And the answer to that, very briefly, you have to go back to the limitations of the study, right? So most of those studies had a max SBP of like 200 or 210 systolic. So one of the pitfalls is we don't really have good evidence in those super, super elevated hypertensive patients about what that exact target might be. So if you're talking like systolic 230, 240, which most of us have probably seen in these ICHs, they're not in that research protocol. So I would not be able to say confidently that 140 is the best target. We're probably going to be a little bit more nuanced in how we lower that blood pressure, especially for those really high ones. In the patient population that's in that 180 to 210, I think we can confidently say that that target of 130 to 150 with a smooth blood pressure reduction without a large variation is best practice and within that first 1 to 2 hours. And I say smooth and without variability because if you take someone from 210 and now they're 130 and you did that in 5 minutes, that's not good. You're going to have rebound ischemia. So my practice is generally, let's get it down 10, 20, millimeters mercury in 15-minute intervals with our normal titration parameters. So you're going to see that blood pressure starting to drop. If I start plateauing on a blood pressure on that next time that it's cycling, then I'm going to increase that, the rate of that infusion, just as like a practical answer. Does that give you full?
Sorry, just to follow up on the second, like with regard to the spot sign, like how soon do you see the difference in the contrast between the vessel and the background? Presumably in the acute setting, we're not going to have the differential on the hospital units. So presumably there's some time that has to pass in case you get on a CT head. Unless you're doing like the CT and the CT head at the same time, right?
Yeah, I think that's a question for you, Peter.
Wait, do you want me to take that? Yeah, why don't you bring that? I think so this spot sign only comes up on a CT angiography, so you've given contrast, and so it actually people have looked at this, but in theory, it's you're seeing contrast, same Hounsfield units as in the vessel. It's just you're seeing that a spot of that many Hounsfield units not in the vessel, right in the parenchyma of the hematoma. Over time, there are people who've looked at like, does it diffuse out and does it diffuse into the hematoma? Does it decrease? But really, when at the time of CTA, you see that spot of contrast in there, and that's the positive spot sign.
The hematoma on CTA itself looks gray, not white. And so you can see the spot sign versus the gray of the hematoma.
Yes.
Right away.
Right away. Yep.
Anybody else?
All right, maybe I'll ask a question then of the audience. Sort of the two-part question. One is, if you, when you have a patient in your ED with intracerebral hemorrhage, how many of you are consulting neurology versus neurosurgery versus some other service? How many neurology? How many? Few. How many neurosurgery? Lots of neurosurgery. Okay, excellent. And then, how many both? Oh, how many both? Yeah. All right, lots of people both. Excellent. So I'm glad you asked that. How many like some other service, right? Or just go to the ICU? All right. They just go to the ICU. And is it basically the intensivist that manages them in the ICU? First of all, that sounds awesome. I love that. And do they go right up or do they sit in your ED for a while first? Depends on the day. So it's effectively the neurointensivists who are managing them, right? If it's closed neuro ICU. And then second, how many people is it residents versus an attending who would see that patient super early? Residents? Attendings? Ooh, with neurosurgery? Residents. With neurology? Fellow resident. And the reason I ask is it goes into this prognostication piece. I know one of the challenges we've faced is that the person who's discussing early prognostication might be like a first or second year resident. No offense to residents, of course, but they don't know as much, and so it can be really challenging that that's the person making the early prognostication. Anybody have a system in place to sort of prevent the residents from too early prognostication? No. All right, we tried to do it, and it's a real challenge. And so I would just advocate to back up what our palliative care folks argued and our prognostication people argued. You really want a system in place that makes sure if you're going to do a DNR order, it should be somebody who really knows what they're doing, as opposed to an overburdened, busy resident, right, who you're calling at 2 o'clock in the morning who has 17 other patients, and the easiest thing for them, right, is to make the patient DNR or CMO. Great. Any last? No. We actually have 5 more minutes, or we can do that.
Okay, if there are any last questions.
So with regard to mobile stroke unit, I know the studies have been validated in Europe, but I know like New York Presbyterian has their, there are a couple of units across the country. Have those European studies panned out here to show that there's actually like a meaningful outcome? Like
Matt.
staffing all the resources that you can warrant to these units to actually have a better outcome.
Yeah, I wasn't really, well, I don't know that any of the studies that I shared with ICH showed a meaningful outcome with mobile stroke units. A lot of times that's not the targeted mobile stroke unit. There's this focus on ischemic stroke in general, but I'm definitely not aware of any kind of American analyses of mobile stroke unit data. So we do have mobile stroke units here all over the place, so take note.
All right, with that, I will bring us to a close so that everyone can head over to the plenary. Thanks for coming.